So basically, I will take this talk again on KRAS mutation to give more strong evidence to support the role of chemoimmunotherapy in KRAS mutation lung cancer. Because we all are aware in driver mutated lung cancer, generally immunotherapy is not the preferred drug. Uh, KRAS is the exception for this. So this was a pooled analysis by FDA in patient for the first line immunotherapy approach in KRAS mutated lung cancer patients. So as we are aware, the KRAS is the most common mutation in the non-small cell lung cancer, and prevalence is approximately in 1/3 of the population. But before a few years, there was no targetable drug was available, but now we have some drugs like sotorasib or adagrasib, which is now in the market. And we know in non-small cell lung cancer, the immunotherapy has changed the outcome. And with the immunotherapy, who are driver mutation negative, they have a significant outcome. As already discussed, the 5-year survival is more than 1/3 or more than 1/4 in the population. So in KRAS, there was this retrospective analysis which has shown that irrespective of KRAS wild type or KRAS mutated, if we give immunochemotherapy alone, you can see that the response rate in wild type was only 29%, against in mutated KRAS where the response rate was 57%. And again, the median OS was higher in patients who are received this immunotherapy. It was 28 months against 15 months. And coming to the combination of immunochemotherapy, you can see that there was no difference in either response rate or median OS, and both with the combination, the response rate and survival was improved in irrespective of the mutation status. So this was the background for the this pooled analysis. And so this coming to the actual analysis, so this was a pooled analysis from across 12 trials. So they included non-small cell lung cancer patients from 12 trials, and the treatment was in the 3 groups. First was the immunochemotherapy combination, then second was the immunotherapy alone, and third was the chemotherapy alone. And they measure, the endpoint was to see the differences in overall response rate and overall survival. And they sub-stratified these groups based on the KRAS mutation status, either wild type or mutant, or one of the common mutant, G12C. And again, they divided these patients based on the PD-L1 status, either high or low or negative. And one more point to be noted that in these 12 trials also included the patients who are EGFR and ALK mutated non-small cell lung cancer patients. And the statistical method used for the objective response assessment was Klopper-Pearson exact method, and for survival was Kaplan-Meier method. And to see this OS hazard ratio was Cox regression proportional hazard method was used based on the KRAS mutation status or PD-L1 score. And so coming to so there was approximately 9,000 patients were reported in these 12 trials, and out of this, only 16% patients had the reported KRAS mutation status. So it was approximately 1,430 patients in whom, out of the 9,000, the KRAS status was reported. So out of these 1,430 patients, 875, making it as a 61%, had a KRAS wild type, and approximately 39%, 555 patients had KRAS mutation positive. And among these KRAS mutation, 11%, 157 patients had G12C mutation. And then you can stratify these population based on the PD-L1 TPS score, either negative or low or high. You can see that in each these of three subgroup, the numbers were equal. And again, the treatment received in each subgroup, you can see that either chemoimmunotherapy or immunotherapy alone or chemotherapy alone was same. There was no any difference between the PD-L1 status or type of treatment received in this KRAS mutated population. And again, coming to the baseline demographic characteristic in all these 3 subgroup of patients, so all the characteristics were well matched, except for our interest, the majority of the population were white population. So there was an representation of our Asian population. Otherwise, histology-wise, smoking status or brain mets were same in all the 3 groups. And coming to the results of overall response rate, so you can see that compared to the immunotherapy alone or chemotherapy alone, the response rate was higher in the immunochemotherapy combination group, and it was in the tune of 50%. And this was similar across, irrespective of whether there is a mutation present or wild type or classical G12C mutation was seen or not seen. But the point to note is that the results with the response rate with the combination was much better than either alone, either immunotherapy alone or chemo alone. again coming to the survival, so again with the combination, you can see that clearly the median OS was in the range of around 20 months compared to 14-16 months with the either immunotherapy alone or chemotherapy alone. So irrespective of the mutation status, the combination of chemoimmunotherapy was much better in terms of response rate and median overall survival. And coming to these are the graphical representation of what we discussed right now. So this is the overall survival curve with respect to the either they received which type of therapy, either combination or either of the alone immunotherapy or chemo. You can see that the graphs are clearly overlapping each other. And this is the OS by the PDL1 status. Again, you can see that there was no any statistical difference between survival irrespective of the PDL1 high or PDL1 low status. And again, in the PDL1 negative, again, there was no any statistical difference in the survival with respect to KRAS mutation or KRAS wild type status. So what was the limitation of this analysis? That this was the only 16% patient had reported KRAS mutation status among the 9,000 population, and they also included the EGFR and ALK mutation positive, which were there in the KRAS wild type subgroup, and the disease characteristic was not well matched, and co-mutational status, as we are aware, KEAP1 or TP53 STK11 is a poor prognostic population. So that co-mutational status was not available. So coming to the conclusion, so patient with the KRAS mutation, non-small cell lung cancer definitely benefit with the immunochemotherapy, and irrespective of the mutational status, they should be treated as a standard non-small cell lung cancer patient. And this benefit is irrespective of the PDL1 status. And so in the future, whenever there is a trial for targeted therapy for KRAS, the comparator arm should be a standard immunochemotherapy arm. So these are the acknowledgement for the original presenter in the ESCO.